invitation. Well, I'm going to talk about below the ankle revascularization. And my first question is maybe easy to answer, because if we have a look at this, and this comes from Roberto Ferraresi, what we see is that iliofemoral and femoropopliteal disease have a weak association with CLTI, and we need multivessel disease to develop CLTI. But when talking about BTA vessel disease, what we see is that a single vessel disease may lead to CLTI. And what does the literature say about BTA revascularization? Well, not that much. The only evidence is that there is lack of evidence. We only have retrospective, non-randomized trial. We have lack of data in arterial flow into the ischemic lesion and BTA. There's not a good definition about what is direct or indirect revascularization, and the efficacy of below the ankle revascularization can change depending on the type of the wounds, the anatomy of the main vessel of the foot, the collateral network, the revascularization technique, and of course, the physician skills. And despite we don't have a robust evidence, what does literature says? Well, BTA revascularization appears to be associated with, with an improvement in wound healing, with shorter time to wound healing, and maybe to reduce major amputation. So, you might agree with me that the cornerstone of limb salvage is wound healing, and when facing delayed wound healing, we are facing an increase in morbidity and medical cost, and of course, this situation will affect a lot to the quality of life of our patients. So regarding the revascularization strategy, I'd like to talk about the Gunderson concept. We follow this strategy. I think we all know this consensus led by Lorenzo Patrone and signed by more than 100 physicians all over the world. This says that direct revascularization is related to increased wound healing rates. This is what Lorenzo was talking. We need to get flow directly to the wound, because this is also related to reducing of the healing time, and this has a relationship with limb salvage. So our strategy is getting blush at the level of the wound. Now I'm going to explain you with some examples of when I think that we need BTA revascularization. In case of non-healing surgical wounds, the first case I will show you is a patient with debridement of foot infection, a diabetic patient. This is the wound, and this was the angio. This was the dorsalis pedis and occlusion of the tarsal artery, which was the target artery. As you see, we recanalize the tarsal artery. We perform an angioplasty with a 2 millimeters balloon. The plantar arch was patent, and as you can see, finally we got a very nice blush at the level of the wound, and the evolution was very good. Another situation is when we have non-healing plantar or heel wounds. This is another case, a patient with this huge heel necrotic ulcer. This was the baseline angio. The patient had a FEMPOP disease, so we thought that it was going to be enough to revascularize the FEMPOP segment. So we performed a recanalization, stenting, and this was the result. Anterotibial artery patent, and the run-off vessel was the dorsalis pedis, as you see. However, the patient didn't run well. The ulcer at the level of the calf was quite good, but the necrotic ulcer at the level of the heel was running good. So we decided to go with him again to the operating room. And this was the baseline angio, FEMPOP segment patent, anteriotibial artery patent. At the level of the foot, pedal artery patent, and as well the plantar arch. So we decided to recanalize the posterior tibial artery, but unfortunately, we had this inability to enter. We performed a subintimal recanalization of this long occlusion. So we decided to go for a contralateral approach through the plantar arch, as you see. But we had this plantar arch perforation. So the only option was a retrograde approach. We decided to perform this plantar arch puncture, this lateral plantar recanalization. This was to check that we were in. And so we performed the bidirectional lateral plantar and distal posterior tibial recanalization. It was quite difficult, but finally we got to the posterior tibial artery. We performed the rendezvous with our 4 French Bernstein catheter, and we performed the angioplasty, posterior tibial, lateral plantar arch, and this was the completion angio. Very nice flow at the level of the posterior tibial, anterior tibial, and the level of the arch, and blast at the level of the heel. And this was the clinical evolution. Another situation is when we have foot ulcers involving more than one angiosome, if we have huge wounds, and we need to perform a complete revascularization. This is one case with high risk of amputation. As you see, this was the baseline angio, a peroneal artery, and at the level of the foot, a recanalization at the level of the dorsalis pedis. We perform anterior tibial recanalization and antegrade recanalization using this support catheter, an 014 guide wire. We managed to arrive at the level of the dorsalis pedis, and we checked we were in the reentry. And as you see, we had an occlusion at the level of the arch. So we performed angioplasty, and this was the completion angio. Quite nice, anterior tibial artery, dorsalis pedis. The arch seems to be complete here, but in the AP it wasn't. We have decided to perform a plantar arch recanalization in order to get to the posterior tibial artery to improve the flow at the level of the heel. So we were not able to perform this recanalization antegradely in an antegrade fashion, and we decided to perform this transcollateral approach with a short Armada XT balloon. Finally, we managed to do it. We pre-dilate the whole track. And once we were in the posterior tibial artery, we perform again the bidirectional approach. The rendezvous. Angioplasty of the posterior tibial artery. And an antegrade crossing. We also needed, here it was too long, that's why I take it off, but we perform a retrograde puncture at the level of the posterior tibial artery. And finally, the angioplasty of the lateral plantar artery, and this was the completion angio. Very nice flow. 2 runoff vessel at the level of the foot, and blush at the level of the calcaneus ulcer. This was the clinical evolution of the wounds, as you see. And another situation, just to finish, is when we have no tibial outflow. So if we have recanalized and we don't have a good runoff, we need to perform a pedal revascularization. This was a case, as you see, anterior tibial artery, which is occluded at the beginning, with a recanalization at the level of the ankle, proximal dorsalis pedis, and distal occlusion of the dorsalis pedis. So we perform this anterotibial artery recanalization in an antegrade fashion with an 014 guide wire. We managed to get to the level of the dorsalis pedis, but we were not able to cross the distal occlusion of the dorsalis pedis, so we perform a metatarsal puncture to perform a retrograde recanalization. Then using an 014 support catheter, we finally get to the distal anterotibial artery, perform the rendezvous and the angioplasty. And also, we use DCB at the popliteal and SFA, and this was the completion angio. Well, we have explained when to do it, but we also need to know when not to. If we are facing limit ulcers affecting just an angiosome, small ulcers, maybe it's better not to try to get into the foot. Of course, in patients, schedules for proximal least frank or support amputations, because we are cutting the runoff at the level of the foot. And when talking about a failure of the distribution system of the foot. We need to keep in mind that we need to have experience to perform this technique, and of course we need to have suitable, appropriate devices. And as take-home message, BTA revascularization is feasible and safe and should be considered in appropriate clinical situations. Mastering bailout strategies is mandatory to achieve procedural success, and meticulous technique with appropriate devices is required. Thank you very much for your attention.